the webinar Mental Health for All webinar series on mother and child mental health. My name is Laura Ochoa. I'm originally from Colombia. I am the early years lead at the Bernard and Leer Foundation, which is a foundation based in the Netherlands with programs all around the world and active portfolios in India, Israel, Jordan, Brazil, the Netherlands, a global displacement effort, and partnerships in different countries that have impact beyond our core countries. I am very happy to be chairing this webinar today, where we're going to discuss further on the mother and child mental health tools and how we can integrate mother and child mental health services into maternal and child health services. As a brief introduction, I encourage everyone to share in the chat where they come from, what is their name, their organization, their position, and share who is joining us today in the webinar. I'm going to do a brief thematic introduction, and then we're going to have panelists introduce themselves and dive right into specific questions with all of them. We also encourage everyone in the audience to complete the Global Mental Health Action Network survey, which is going to be shared in the chat as well. So please help us improve also the webinar series. So as I was briefly saying before, the Bernard and Leer Foundation has worked for more than 6 decades around the world, helping young children and the people who care for them to improve their outcomes, especially towards early childhood development. 3 years ago, we decided to strengthen our efforts and pay more attention and support into caregivers' mental health, recognizing that its crucial role in giving babies and toddlers the best start in life. As a result, we have supported the development of the WHO guide for integration of perinatal mental health in maternal and child health services, which is one of the tools that we're going to learn more about today. And it is meant to engage in mental health promotion, prevention, treatment, and care in low and middle income countries. As a brief introduction, I just want everyone to keep in mind 3 facts and connections between maternal mental health and early childhood development. First of all, poor maternal mental health in general and caregivers' mental health in general, as we know, has an impact on children's health and developmental outcomes very early on in life, from pregnancy and for a very long time during their life as a child and even as an adult. Mothers experiencing mental health challenges can find building stable, strong, and loving relationships with their child very difficult when they have mental health conditions. Research has consistently shown that mental health conditions in mothers in the perinatal period is linked or associated with various childhood outcomes such as low birth rate, prematurity, difficulties to breastfeed or to generate and create healthy mother-to-child attachments, developmental delays, and various health problems later in life. On the side of the mother and her well-being, we know that pregnancy is a life-changing experience that can impact women's mental health. The realities of pregnancy and early parenthood can leave a mark on women's identities, women's physical health, the opportunities they have to generate income, their economic opportunities, and their social opportunities. According to WHO, 1 in 5 women in low and middle income countries experience mental health symptoms during pregnancy and right after birth. However, most women do not receive that adequate care they need. Furthermore, on top of that, there are specific categories of women that actually are at a higher risk of developing mental health symptoms. These include adolescent mothers. These include women living in poverty or in humanitarian contexts, women exposed to domestic and gender-based violence, women with disability, or with pre-existing mental health conditions. They may need targeted support and services. Today, we're going to learn about new and existing approaches. We're going to learn more about the WHO tool and experiences in different contexts about how health providers and practitioners are integrating mental health services into mother and child health services in overall during this critical period of time in the antenatal period. So without further ado, I'm going to ask each one of you to introduce yourself. I'm going to basically choose as I see it in my screen. Melanie, could you introduce yourself, and then we keep going, and then I'll start with the questions.
Sure, thanks, and good afternoon, good evening, good morning to everyone from where you are. My name is Melanie Picolo. I'm a nutritionist, and I am based in Mozambique with Pat, and I lead our maternal, newborn, child health and nutrition and early childhood development team in Mozambique. It's great to be with you today.
Thank you, Melanie. And Sylvie?
Good afternoon, everybody. My name is Sylvie Ramelet. I'm a nurse by trade, and I'm a professor at the University of Lausanne. And today I'm representing PMNCH and the healthcare professional constituency.
Thank you, Sylvie. Neerja?
Thanks, Laura, and hi, everyone. I'm Neerja Chowdhary, a psychiatrist who works in the brain health unit in the mental health department in WHO in Geneva headquarters. I coordinate the department's activities in perinatal mental health, and I work alongside our colleagues in maternal and child health, sexual and reproductive health, as well as our country and regional offices. And in fact, the guide that we've developed that you'll be hearing about in more detail has been done along with our regional office in Africa. So and I'm very pleased to be here today.
Thank you, Neerja. Laura?
Hi, good morning, good afternoon, good evening, everybody. Delighted to be here. My name is Laura Fitzgerald. I'm an American nurse midwife and a senior technical advisor with JPIGO and USAID's Momentum Country and Global Leadership Project, where I support our work on maternal mental health.
Thank you, Laura. And Terna?
Thank you very much. Good afternoon, everyone. Good morning. My name is Terna Abege. I work for Save the Children, and I'm based in Nigeria, responding to a woman in a humanitarian context. And I'm glad to share with you our experience, how we integrate mental health into maternal nutrition and health. Thank you.
Thank you so much, Terna. So without further ado, let's go to you, Neerja. Let's start with the first question. What learnings can you share? What are some of the key recommendations that the new WHO guide brings with it, and how can precisely healthcare providers prioritize? What do they need to prioritize when integrating perinatal mental health into their services?
Thanks a lot, Laura, also for the support that BVLF has provided us in the development of this guide. And also thanks to the Global Mental Health Action Network for organizing the webinar on this really important topic. Laura, you very concisely framed why it is important to address perinatal mental health, not only in terms of the alarming number of women who experience perinatal mental health conditions, but also the widespread and intergenerational impact that these conditions have. It is exactly to mitigate this that WHO developed the guide for integrating perinatal mental health in maternal and child health services. And if I can ask for the first slide, please. The guide is meant to assist MCH managers, health service administrators, as well as policymakers in what they need to do in order to provide services for women who are attending MCH care. The actions within the guide can be adapted based on the resources in each setting, the funding available, the staff available, and the degrees of service intensity that might be needed. Essentially, the guide has three key messages that run through it. One is that treating perinatal mental health improves not only mental and physical health of the mother, but also has the potential to improve child health as well as development outcomes. Secondly, There are evidence-based interventions for the prevention and management of perinatal mental health conditions. And finally, these interventions can be provided as part of routine maternal and child health care by trained non-specialist healthcare workers. The guide reviews evidence-based interventions that can be included in a package for integration of perinatal mental health into maternal and child health care. And the next slide shows you how this can be done in a stepped care manner. So basically, what we can do is provide a supportive and respectful environment free from stigma to all women, provide promotion and prevention interventions to all women, such as psychoeducation, stress management, strengthening social supports, promoting of functioning, recognition of mental health conditions, the use of screening tools, and identifying risk factors for perinatal mental health. Then there might be women who have greater needs and who might have mental health conditions, and we can provide them with psychological interventions, with medications if needed, and referral to a specialist. There are tools that provide these evidence-based interventions that can be delivered by non-specialist health workers. Like I said earlier, examples of these are WHO's MHGAP interventions that are evidence-based interventions that can be used by non-specialists in resource-poor settings, and they include recommendations for treatment of mental health conditions in the perinatal period. There is also an effective psychological treatment that WHO has developed called the Thinking Healthy program, which is a cognitive behavior therapy-based treatment and has been used in many parts of the world to train community health workers to be able to provide care for perinatal depression. The next slide. The guide also elaborates the steps for delivery of these effective interventions. If we have to integrate mental health within MCH services, we need to form a core working team that is responsible for overseeing this integration, engaging those important for funding, delivery, and uptake. A situation analysis and needs assessment are useful to understand what mental health support is needed and what is already currently available. Once targets are agreed upon, a plan and a budget to achieve them needs to be developed. Careful preparation will ensure that maternal and child health service providers are adequately trained, supported, and supervised, and also that there are clear pathways to provide care and to address stigma. We need to ensure that the provision of care promotes good mental health and enables access to treatment for all women, and the strategies for delivery should be suitable for that particular setting. The next slide. Laura has already emphasized the need to address what women who are more vulnerable to mental health conditions during the perinatal period might require. Women who have these additional needs during pregnancy are likely to experience greater stigmatization and may struggle to engage with services for various reasons. So it is important for healthcare providers to be aware of these needs and how to support them in the maternal and child health services, and where to refer for specialist or additional care when this is required. The next slide. Finally, the importance of monitoring and evaluation cannot be emphasized enough. In order to understand what is going well and what should be improved upon through continuous quality control. The M&E plans for perinatal mental health care should be built and integrated into local MCH services. It is important also that information is collected by various methods, either through surveys, written responses, interviews, focus group discussions, and also collected from a variety of people, such as women who use services, as well as MCH service providers. Finally, let me conclude by saying that maternal and child health services represent a unique opportunity to support women in a respectful and stigma-free environment, leading to increased attendance, better engagement in care for women as well as their babies, and for greater overall well-being. Thanks a lot, Laura, and back to you.
Thank you, Neerja. That's a great introduction on the framework that we're going to be discussing further on. How does this look like in practice? And we're going to try to learn more about it, our actual experiences in different contexts. And now I'm going to move directly to Terna in Nigeria and Save the Children. And could you share with us also what you guys have learned in trying precisely to integrate mental health into perinatal and maternal care with Save the Children?
Thank you very much. I want to say that the psychological, emotional, and social stability of mothers is one of the requirements for breastfeed flow to continue lactation, that is secretion of the milk, especially in breastfeeding mothers. Maternal mental health disorders typically occur at the time the woman is pregnant and the first year after the baby has been born. Over time, depression has been recorded as one of the most common mental health disorder among mothers, followed by anxiety disorders such as generalized anxiety, panic disorder, and a bit of birth-related post-traumatic stress disorder. Because for some mothers, it is a horrible experience, very unpleasant experience. And after that, they live with psychological wounds, which to some extent been diagnosed as a post-traumatic stress disorder. And to some mothers, they hit the psychotic state, a situation whereby most mothers lost contact with reality. In Nigeria today, Save the Children has integrated mental health into her health and nutrition program. I work in a humanitarian response in Northeast Nigeria. And like I said before, I'm the mental health specialist. So what we do on this project is that mothers has been identified and screened with maternal mental health needs using a standardized tool that measures depression, anxiety, and stress, and post-traumatic stress disorder. With this diagnosis, treatment plans were developed by the mental health specialists that includes psychoeducation, individual and group counseling. So these mothers went through these sessions, 5 sessions, to actually support them to overcome the overwhelming symptoms of mental health issues. So we also provide follow-up sessions to actually understand the progress in terms of coping strategies that were developed during individual and group counseling, and also to monitor progress. So after that, evaluation was also conducted, and then we decided to form some mothers into supportive groups, so that they'll be meeting from time to time, twice in a week, and be discussing some of the coping strategies that they have learned during the sessions that can build their resilience. Today, we have recorded significant impact, and I am here to say that most caregivers are now well informed about their mental health issues associated with perinatal and postpartum period, and gain mechanisms to solve their mental health needs through the individual and group counseling sessions, and with the support of the psychoeducation, which is a therapeutic, psychotherapeutic technique. Again, another lesson we have learned that needs to be shared is that in terms of thoughts, most mothers conceive thinking errors, intrusive thoughts, nightmares, and difficulty concentration. And they have submitted that they have significantly improved in terms of their thinking patterns. Also, emotional problems. One sad end of depression is that survivors, mothers submitted suicidal ideation, such as hopelessness, restlessness, and worthlessness. So with the counseling session, and you know that this suicidal ideations, if not managed, if not supported, it moves to suicidal attempt, and if nothing is done, is lead to suicidal, finally committing suicide. And with the counseling sessions, these have supported these mothers, and they have hope, and they have regained their emotional distress. And in terms of social well-being, they have improved in their relationships. Again, mothers are able to breastfeed their babies sufficiently compared to when they were not diagnosed with mental health needs. Another lessons that I have learned is that addressing maternal mental health needs among caregivers of infants that were admitted at Save the Children International Stabilization Center has also improved relaxation techniques applied by doctors and nurses. So these are some of the lessons that I want to share with you that we have recorded so far. Thank you, and over.
Thank you, Terna, so much for sharing the lessons on why it is so important and how we can see results directly coming out from mental health interventions within existing nutritional health integration services in Nigeria. Now I'm gonna go back to Melanie. I would like to ask you, what does mental health care for mothers look like in Mozambique? What is your work looking like right now? And what improvement also do you hope to see to existing health services in the year ahead?
Thank you so much, Laura. So in Mozambique, the notion of integrating mental health in these more transversal services like maternal and child health is still very new. In 2020, PAT supported the Ministry of Health in Mozambique to adapt PHQ-9, as well as the WHO Thinking Healthy counseling cards to the Mozambique context, and helped pilot these for about 6 months in a province, Maputo province in the south of Mozambique, as part of routine postnatal care services. So the maternal child health nurses were trained to use these tools for screening and counseling for postpartum depression. And based off the results of that pilot that were available in 2021, and for which a brief was produced and just shared in the chat for the link, the results showed that the intervention was acceptable, it was feasible, although it was more feasible if using a shorter version of PHQ-9, so PHQ-2. And it actually led to a 3.3% postpartum depression detection rate among eligible women attending postpartum services. And these results informed the Ministry of Health's decision to integrate postpartum depression screening and counseling in recently updated postnatal care guidelines, as well as community health workers' curriculum. These are still under review, and we hope they'll be approved soon. And the review of antenatal care guidelines are also planned. So really, after the results of this pilot, the Ministry of Health, Mental Health and Maternal Child Health departments also came together to really think about the lessons that were learned there and think about what's next. So we collaborated with them to refine and simplify the screening, as well as the counseling tool. So PHQ-2, and then these non-specific criteria using the full PHQ-9 tool, as well as simplifying the counseling tools a little bit further, because that was also a learning from the pilot that MCH nurses really needed much more simplified and to the point tools. And the results also, the recommendations of the MCH nurses was that these should also be expanded to antenatal care services, and to also focus on the adolescent girls, because of what you shared precisely at the beginning, that adolescents are so much more prone to depression, and we really have a high rate of adolescent pregnancies in Mozambique. And so currently we are supporting the Ministry of Health in expanding that pilot a little bit, not in terms of geographical area, but in terms of expanding this perinatal, not only postpartum depression, but perinatal depression screening and counseling in ANC and PNT, so antenatal care and postnatal care services. Again, conducted by maternal child health nurses, closely supported and mentored by mental health providers at this primary health care level. And also to have this focus on adolescent girls. So in the year ahead, what we hope to see really is that these interventions are taken to scale, because we definitely see the demand there. So the province, Maputo province, that definitely has in their early childhood development plan that we helped also develop to create, to scale up these services in the whole province. And there's also this appetite from the Ministry of Health to scale it up to the whole country. And to see also increased demand for these integrated perinatal mental health services at the community level by normalizing perinatal mental health problems and increasing awareness of the existence of support services. So to do that, PATH plans to assist the Ministry of Health in establishing a maternal mental health technical working group, because we're not working alone in this area. So really, we need to bring the efforts together and to provide the Ministry of Health with technical assistance to approve the refined perinatal depression screening and counseling tools based off the results of these extended pilots. And hopefully support them in scaling up these to the whole national territory, given the upcoming approval of the postnatal care guidelines, and hopefully soon antenatal care guidelines. And so by approving that, we hope that the Ministry of Health, through existing maternal and child health services, can help scale this up to the whole country. And also, now that the Ministry of Health is revising their community health workers subsystem, it's also our hope that this will be taken to the community as well for both the demand creation and for early screening, so that these services can reach all women needing them. Thank you.
Thank you, Melanie. It was fascinating actually to listen to a story of scaling up different efforts and progressively building up a system that now has an appetite and a demand for services addressing perinatal mental health. And there is a recognition from the partnership from Ministry of Health and from communities also that this is important, that needs to be integrated very early on and expanded widely. So also great to hear about the focus on adolescent mothers. So we look forward to learn more what you guys do in the future. Now I'm gonna switch to Anne and Sylvie. From your experience from PMNTH, how can mental health be integrated into existing family support interventions?
Okay, maybe first of all, why family is important. I think Laura and Neerja, you really set the scene about why perinatal mental health is important and how it affects the woman and the mother and the child. But in fact, it's actually the whole family that is affected when the mother is ill. And so, you know, there's maybe a partner, siblings, so the whole family is affected. And what is family support? It's actually very broad, but it concerns all healthcare professionals across the board: obstetricians, midwives, nurses, pediatricians, psychologists, and so on. And I think the guide of the WHO guide really explained very well the step approach of care. And what is difficult on when you are in the first line is really to make sure that you actually refer to the right person who have the right competency to actually take the person in charge and look after them. And I think for this, interprofessional collaboration is key for this, because as the guide really well depicted in is that, you know, you have different level of severity of mental health, where you may not necessarily need specialist referral, but it's really important to actually not miss the opportunity to get that referral. So that's why it's really important to actually train all healthcare professionals about perinatal, about the risk to start with, because we know the risk factors. And as you mentioned, Neerja, on one of the PowerPoint that is in the guide, is that you have many risk factors, but a lot of people have numerous risk factors. And you can only actually identify those risk factors if you actually take the time to talk to the mother, to the family, and identify those risk factors. It's really also really important to know the protective factors, and we know that social support is a protective factor, and family itself can be a supportive resources, because families have resources, resilience, and strength as well, and family support and where healthcare professionals can have an impact on. They can identify those resources and make sure that you can action some support and refer to specialists if the problem is severe. What I wanted to mention as well, one thing is about respectful care. It's mentioned in the guide at several places, and I'm actually glad to say that PMNCH will be launching soon a new position statement on respectful care that is in response to women's demand. And we actually pledged within the healthcare professional constituency to improve the quality of care that we provide, because there's still a lot of poor quality of care, neglect, and abuse as well within the health systems at different levels and different countries. Of course, it can vary from setting to settings, but there's still a lot of improvement to make. And respectful care is also about, family-centered care, patient and family-centered care. And nurses, midwives, pediatricians, obstetricians are very well equipped to actually apply person and family-centered care, and they should lead the way. And that includes, respectful care and listening to families. And that way we know that when families, the patients and families are treated as partners and equal, and they are empowered, we actually improve the quality of care.
Thank you, and Sylvie, for highlighting and calling us also to remember to be respectful to the mother and treat the family as partners, and especially the mother, but also the entire family, as they all are participants and they're affected, and they all have their own feelings and mental health to care about in this time, and it should be a matter of everyone involved. Also, you talked about collaboration with the entire healthcare professional systems and all the different roles. They should all be engaged in promoting perinatal mental health. Now I'm gonna go finally with Laura from USA Momentum, and we wanna learn more about the initiative in itself, and how and talking about collaboration, how can we effectively collaborate and partner with different types of stakeholders at the national and global level to promote maternal and child mental health?
Thank you so much for that question, Laura. And it's actually one that our team has been asked a number of times, which we take as a compliment. I think as MCGL, we've been able to engage a varied group of national and global stakeholders by design, and it has to do in large part with the way we've sequenced our major activities. Our work on maternal mental health with MCGL started out with a global landscape analysis. That was about 2 years ago now. And we were looking at perinatal mental health with a focus on low and middle income countries. So what do we know about the burden of disease of common perinatal perinatal mental health disorders, about risk factors, and Neerja touched on a number of these, about implementation approaches such as the ones that we've been hearing about today here in this webinar that have been tried and that have worked, and what can we learn from them, and about what are the remaining gaps in the literature and in implementation research. And so this work included key informant interviews and focus group discussions with about 60 experts, and they were coming from the fields of mental health, from reproductive, maternal, newborn, child, and adolescent health, from faith-based organizations, humanitarian workers, nutritionists, gender-based violence experts, advocates, and program implementers from all over the world. And I've seen a number of familiar names in the chat this morning, so it's great to see our collaborators here with us. So from the very beginning, we were committed to learning from and bringing together diverse perspectives and voices around this issue. It wasn't exhaustive, it wasn't perfect, but it was really important to us to try to do that. And we carried that philosophy forward in establishing a technical working group that put together a global 3-day virtual technical consultation on maternal mental health in September 2021. And then this past year, we were working together with that same group around developing a global perinatal mental health theory of change. And these efforts were really led by experts from those same diverse fields and backgrounds, coming from diverse geographic areas. They included women with lived experience, representatives from local and non-governmental organizations, Ministry of Health folks, advocates, implementers, funders, researchers, and representatives from global agencies like WHO and the UN. And this was quite intentional. And we would consistently check in with each other to say what points of view, what regions, what kinds of voices aren't we hearing from that we need to make sure are included. We were mindful of not wanting the big global bodies to necessarily take center stage in thinking about women's experiences and what approaches work best for women and families in different kinds of contexts. In developing the theory of change, for example, we worked with an India-based human-centered design firm called Quicksand to develop an inclusive and thoughtful process that would really help distill folks' insights and stories and contributions. And part of this process involved grounding all of our theory of change conversations in the journey of a woman who is experiencing a perinatal mental health issue. And we found this to be a really helpful way of humanizing the subject, of bringing each of us back to our own personal stories and experiences and those of our loved ones, and creating this commonality, this shared vision, was this emotional connection with the urgency of the work. It really created some common ground and a shared commitment to success. We had colleagues who told us, folks who have committed decades and their careers to working in perinatal mental health, but who sometimes felt like they were working in isolation, that they had now felt connected to this community of folks who are as invested in really elevating the issue and the urgency around perinatal mental health, and how empowering and motivating that was, which is really gratifying for us to hear. And we're now in the process of launching a community of practice on perinatal mental health to help sustain this spirit of collective engagement and knowledge exchange across countries, across fields, and across healthcare contexts, and looking forward to being able to share that information shortly. Thank you.
Thank you, Laura, for reminding us the importance also of creating communities to share and humanize this important topic, and how these are the experiences of women and families all around the world, and how important actually to recognize first those stories and the lived experiences and the human aspect of these issues. So thank you for sharing that. And I also want to recognize and connect a little bit with what Terna was sharing about Nigeria, like the communities or the support between mothers, also peer-to-peer support to address some of these issues through collaboration and community support. So it's not only in the healthcare professionals, but it's also a part of the entire community to care for the mothers and the families going through these to potential mental health condition symptoms during the perinatal period. So now we would like to address some of the questions, and I'm going to invite some of the panelists today to share further more. So I have one question that is about especially working on communities and urban slum communities. Like how can informal settlements, informal communities can also implement mental health care programs, connecting with healthcare services, but relying probably more on lay mental health counselors, or there's a way to train themselves. So like how can they be engaged also, like, or how can we work in this context specifically to promote maternal and child mental health? I don't know if, like, for example, either Melanie or Terna or even Neerja or Anna, like anyone actually, or Laura actually would like to address this question in particular, which is a little bit outside the healthcare system, but is targeting the communities that are more in need. No volunteers? Okay. So in this case, I'm gonna then, we're gonna take that question and bring it back as a homework for us to like follow up on that one. And I'm gonna then go ahead with the second question that is more directly on the guide. So this is Neerja for you. The childhood, so I'm going to read it. Childhood emotional relational adversity is the strongest predictor of adult physical and mental health and perinatal mental health problems. However, it is not listed among the risk factors in the guide, or the fact that non-trauma focused psychological interventions have less good outcomes in the 50% or above of mental health care users who have historical trauma. Therefore, what steps could we take to enhance trauma-informed approaches in low and middle-income countries?
Thanks, Laura. That's an interesting question, and I don't know that I have a direct answer to that. It's true that we don't focus on childhood trauma in the guide, but we've tried to address adverse circumstances that women might face in addition to being victims of domestic abuse or violence, and also women who might be in humanitarian settings and what special needs they would have. I think we do work with the interagency group on women who are exposed to difficult circumstances in humanitarian settings, and we have the MHPSS working group that WHO is a part of. And as a part of that, addressing the needs of women exposed to these situations, exposed to conflicts, exposed to violence, is something that we've tried to highlight. Having said that, yes, facing childhood trauma, we don't specifically address, and I'd like to hear of anyone who's working in the field who has experience in that area.
Thank you, Neerja. I'm gonna now jump to Laura about the momentum theory of change. How can different organizations use the theory of change if they would like to?
Sure, thanks. So the theory of change, and I apologize that I'm not able to share that yet. We'll be posting that online this week and can get back to you all with the link for that. But as many of you know who were working with us in developing that, it's organized according to the socio-ecological model. So it's sort of built out by layers that go from interpersonal to community to service delivery ecosystem to that sort of national policy level. And at each level, there are suggested evidence-based illustrative interventions that we know to be effective and to work, linked with outcomes, linked with the ultimate impact. So wherever folks are kind of working along that sociological model spectrum, they can kind of plug into where their sphere of influence is to see kind of what would make sense according to what they do. And the idea isn't that this is going to tell you necessarily exactly how to do it, but rather it's just a shared common framework so that we can all kind of be speaking the same language and collaborating in an effective way. So, you know, it needs to be complemented and supported by the work with the implementation guide, with metrics and other implementation supports, as we've heard this morning. But the intention is really to try to consolidate what we know about what works and help to share that out by level of operation. Thanks.
Thanks, Laura. Now I have another question here on how can maternal mental health be more successfully integrated for mothers who are facing long stays in NICU after their child is born. So Melanie, do you want to tackle on that one? Or and Sylvie, you want to tackle on that one? Yes, go ahead.
Well, you know, we can
or both. Okay, we can do and Sylvie and then Melanie.
Yeah, okay, maybe I start, Melanie, is that okay? Yeah. In what we know, there's a lot of evidence that shows, you know, the mental health problems of parents who have a child in neonatal intensive care and pediatric intensive care units. We know that about up to 40% of the parents who actually go through that journey actually have post-traumatic stress disorder during 1 month after and month after PICU discharge. So whether it's a prolonged effect of for instance, a trauma during pregnancy or birth that has an additional trauma of having a child in ICU, we don't really know, but the fact is that we have the problem of mental health is actually very high in intensive care. And the longer the stay, the more prevalent are the mental health problems, of course. So this is fairly new data and evidence that we have now. And what is starting to be put in place is in neonatal units, we have, like programs like the NITCAP and, other programs like the COPE program that help mothers to actually cope with the uncertainty of the outcome of the child and all other complications that you may have during the hospital stay. For the pediatric ones, where you also have babies who after cardiac surgery, for instance, we have less support in place because it's a fairly new phenomenon. But consultations start to be put in place. So family support consultations have been put in place for high-risk parents. And that includes, again, not just the mother, but the whole family. So the partner, grandmother, siblings, whoever are, the main carers and affected by the problem.
Thank you, Sylvie. Melanie?
Yeah, I can add that, small and sick newborns need I think, a specific package of care. And we've been at PAT, the maternal newborn child health and nutrition and early childhood development teams have really been working on, this concept of what could that package look like. And it needs to be very integrated, lactation support, mental health support for caregivers, really not just the mothers, but the family. Of children facing long stays in NICUs, stimulation, all these package of care that needs to be provided to mothers. And really, I think it goes at the policy level with the Ministry of Health, working with Ministry of Health to integrate these interventions in newborn care. Services, you have this what's the acronym in English? But I think the NCAP, every newborn care action plans, that the countries are implementing, and we've been working to integrate like stimulation and mental health, like small sprinkling it here and there, so that we start that. Preparing primary health caregivers to facilities at higher levels also to provide those integrated services. But I think really we need to determine what's this feasible package of care that can be delivered at that level when you're trying to address so many problems. But you can't ignore the realities of what Sylvie was just saying. The evidence is showing that there's this gap on mental health of caregivers. So we need to really understand, what's this minimum package of care that we can provide that addresses all those specific needs of small and sick newborns and their caregivers. So something we're very much interested in also conceptualizing, testing out in our programs. So that's what I could add.
Thank you, Melanie. Back to the guide. I know actually in general about the topic, what do we do in settings that don't have the wide array of professionals? That the professionals, meaning psychiatrists, psychologists, or specialized professionals ready to be trained and integrate or ready to provide the service directly. So what can we do in those type of settings? This I would even extend it to say, what can we do in humanitarian settings? And I would like also Terna to maybe add a little bit more on the specifics of humanitarian settings and how we integrate it. So maybe Neerja, we start with you, and then Terna, you could add on the humanitarian aspect. Thank you.
Thanks, Laura. No, that's a really good question. In terms of what can we do in settings where there are not enough specialists, I think that's actually one of the key kind of focus that we have in the guide. I think we all recognize that overall, not just perinatal mental health, but mental health overall, has people have limited access to care, most often because that there are limited specialists to deliver treatment. And that is why the whole focus on task sharing, where non-specialists can share the tasks, they can be trained. This training is not extensive to be able to recognize mental health conditions, to be able to deliver these conditions. Up to a point, like we say, that's why we talk about the stepped care approach, where most of the care can be delivered by non-specialists in primary care, in maternal and child health care settings. There might be a small proportion of women who will still need specialist care. So that also reduces the load on the specialists. So through training of trainers, we develop, this workforce of people who can then train the non-specialist healthcare providers to deliver care. So I think that's really the model that we need to think about. Also to think about not only providing care in in-service settings, but also thinking about strengthening pre-service training for nurses, for midwives, about how they can, mental health, provision of mental health care can be a part of the training that they receive. So when they go out to, into the workforce, they're already well equipped.
Thank you, Neerja. Terna, do you want to add something or more like how to work in humanitarian settings?
Yes. I think let me add to what she said. In a humanitarian setting, there's this a guideline that guides our humanitarian work. We have a guideline called Interagency Standing Committee on Mental Health and Psychosocial Support. And looking at the definition of mental health and psychosocial support in the humanitarian setting, it has to do with making use of the local resources to promote mental health of the survivors. And when the local resources are not enough, we now also use the outside resources to also complement. The idea is to promote and prevent mental health issues. And the guideline has a pyramid of intervention. And the pyramid has layers. And the first layer talked about the provision of basic services, such as security, health, food, and shelter to people in need of these services. So what we do at that level is for mental health practitioners, we advocate for these services so that the people who are in need can get these services. And when these services have arrived, we also ensure that the administration of these services will take into cognizance the nursing mothers, the pregnant women, physically challenged persons, to also be prioritized in providing these services. So we should also move to the second layer. We talk about supporting community members and family members to address their mental health challenges. The integration is talking about integrating mental health into community settings. So we have healthcare centers, we have schools, we have clubs, we have so many other places that we can integrate these mental health services. Some of the child-friendly spaces, women-girl-friendly spaces that we have is at the community layer. So we move, there are some significant persons that with this support, they still have some significant mental health challenges like depression, anxiety. Then we move to the second layer, whereby we have non-specialized services. At this level, you discover that there are people who provide these services, but they are not specialists. So for us in Save the Children, we use this this guide to actually integrate our services. In health and nutrition, we have trained health workers, community health workers, to actually provide these services, such as psychological first aid, psychoeducation, individual and group counseling. So they're also trained to actually refer cases that they can now handle to the specialized services, where you have the psychiatric doctors, the clinical psychologists, the occupational counselors, and so many other professionals. So they are trained. At that level, we train because the specialists come down the ladder to build the capacity of those who can provide services, not specialized, services, but they're not specialists, at the first layer, second layer, and the third layer. So you can agree with me, there's a wide gap in mental health service. So this guideline has helped so much to actually address, some of the mental health challenges, especially in humanitarian context, just like what a mental health gap, like she said, is also supporting in this regard. Thank you.
Thank you, Terna, so much for sharing your last thoughts. We cannot keep going with questions because we are almost to the hour. So now I'm going to do a quick round with the panelists or for our last thought or tweet of the webinar. And I would like you guys to complete the following sentence, thinking about the 240 characters, please. We must integrate mental health in maternal and child health services because, and I'm going to start with Laura.
Because all women deserve to experience optimal mental health, not just because it improves physical health outcomes for ourselves and our children, but because it is our fundamental human right.
Thank you, Laura. And Sylvie?
It's hard to be better than that. Because it actually concerns everybody in the society.
Thank you. Melanie?
Well, because it's time we acknowledge, normalized, and cared for the hardships that come with just being a mother.
Thank you, Melanie. Neerja?
Because there is no maternal health without perinatal mental health.
Thank you. Terna?
Because it can make women mental health better in their postpartum period and will help their children receive more health services.
Thank you. And my own contribution is because it sends mother on a pathway towards a more connected and empowered motherhood experience. Thank you everyone for joining us today. So this is how we wrap up also this very important conversation. Thank you everyone that stayed connected up to the end. Thank you for all the questions, all the comments and sharing the projects today with us in the chat. I need to remind you before I forget that the next webinar hosted by United for Global Mental Health, which I forgot to thank at the beginning, is going to be on the 13th of December, and it's going to be on mental health and human rights at 2 p.m. London time, if I'm correct. Registration link will be in the chat, so please register to that one. And of course, you can continue the conversation on Circle. So some of the questions can be addressed there and also connect with other colleagues. To all the panelists today, thank you so much. It was a pleasure to have this conversation with you. And see you on the field and also in upcoming webinars as well.
Thank you.
Thank you. Bye-bye.
Thank you.
Thank you.